Good afternoon, everyone, and welcome to today's webinar, which is part of a series of online orientation for clinicians and healthcare workers that the Disease Surveillance Department of the Ghana Health Service. Good afternoon, everyone. Okay, sorry for that. I mistakenly muted myself. So today's webinar is going to be on acute flaccid paralysis, which is one of the basic foundations of every surveillance system. Because polio, which is AFP, which is a proxy used for polio, is a polio-free country as an extension of the whole of the African region. So it is important that we have a very robust system that is able to detect cases of AFP, which is a proxy to that. So today we are privileged to have seasoned experts in the area of polio and AFP by extension to take us through this very important webinar. My name is Dr. Azuma Abdul Tawab. I'm the coordinator for international health regulations for Ghana. I will be moderating this webinar. So some ground rules before we start the whole session. This webinar is MDC accredited, and also for the allied health professionals, the Allied Health Council is also accredited. The presentation will be made by our seasoned experts. We wouldn't be able to unmute ourselves, so we'll make use of the Q&A. So colleagues that have questions during the presentation, you don't need to wait till the end. You can put your questions in the Q&A. So at the end of the presentations, we will take the questions. So to start immediately, I want to invite our very own Dr. Dennis Lai, Senior Public Health Specialist and Deputy Director, Surveillance of the Ghana Health Service, to give us a brief introduction and objectives of today's session. Thank you, and over, Dr. Lai, if you can hear me.
Yeah, thank you very much, Dr. Taub. And I think I'm happy so far seeing the numbers on the call, given the short notice, and also the fact that it's a Sunday afternoon. So thank you all for making time to join in on this call. I think that it's a very important topic, as you have highlighted. So I'll go ahead. I have a few slides to share. Ni, if we can take this off so that I can share the. Okay, so this, as Dr. Taub mentioned, is something we are doing as a department within the Ghana Health Service, the Disease Surveillance Department, is to provide some continuous orientation. I think exactly a year ago, December last year, we had a similar session. It was targeting mostly our clinicians, the doctors and the physician assistants. But we did also get colleagues from the other professions joining. And so that's why we've expanded it this time. Yes, some of the work or revolve around clinicians, but generally we want to also make sure that all colleagues within the health system appreciate the roles they can play. And so we have set a few objectives for ourselves. First of all, we want to look generally at polio surveillance. What do we mean in this country when we say we're doing surveillance for polio? And then look critically at the role clinicians are playing as far as acute flaccid paralysis surveillance is concerned. There are some aspects that can only be played or can be undertaken by clinicians. And so that is why the emphasis is on that. And particularly if we look at what the National Polio Expert Committee looks at, they will highlight some challenges, but I think the role of the clinician is one of the critical areas that we're looking at. So that is why we're highlighting this, to be sure that clinicians on this call are clearer in their minds on their role. AFP differential diagnosis would also be reviewed as part of this session. And then, as I indicated earlier on, we'll look at some of the challenges as far as our surveillance system for AFP or polio for that matter is concerned. And this will draw on the expertise of the National Polio Expert Committee. So I have to say that two of our presenters this afternoon are members of this National Polio Expert Committee. Professor Adoyebo, who is the chair and who also happens to have taught me some 2 decades ago as a medical student. So he's my lecturer. And also Dr. Charles Hammond, who was my senior in medical school as well. And so these are very seasoned experts as far as the issue of polio, its surveillance, and the clinical issues are concerned. And then we'll also have our National Public Health Emergency Operations Center manager, Dr. Joshua Atta, who would also be taking us through some of the issues around polio surveillance. So we have a very rich panel, and we're hoping that at the end of this workshop, for those of us who may never have been in a workshop such as this, we'll get some clarity. But even for those who have been in similar workshops or, for example, participated in last year's, we'll get some further clarity on the surveillance system and the role of clinicians and other healthcare staff in AFP surveillance. Most importantly, we also want to be aware of some of the challenges that come up as far as the work of the National Polio Expert Committee is concerned in the classification of AFP cases and what potential mitigating factors we would have picked up at the end of this workshop. Beyond this, we want everybody to be playing an active role in AFP surveillance. And so whether you are a doctor, a physician assistant, a disease control officer, a health promotion officer, health information officer, whichever category you belong to, I think that if for nothing at all, the barest minimum is to be able to tell what can be seen or what would direct you to suspect that somebody could have polio. And so acute flaccid paralysis as the surveillance proxy is concerned. So we're hoping that beyond this workshop, we would all play an active role in helping Ghana to achieve polio eradication as has been set globally. So on that note, I want to thank you all once again for making time to join this very important CPD. And as has been indicated, we've gotten accreditation by the Medical and Dental Council and also the Allied Health Professionals Council. And so colleagues who join in and stay on the call, we would be sharing your details with your respective regulatory bodies so that you can be allocated the CPD points as agreed with your respective agencies. So I want to thank you all very much for the time once again. And over to you, Dr. Tawab.
Thank you very much, Dr. Lai, for the presentation and setting the tone for today's CPD. Now we know that we have a clear-cut job in this CPD. To kick off the main work of the CPD, we will want to look at the acute flaccid surveillance performance over the period of time. Because if we don't identify the problem or the challenge, we wouldn't be able to address it well. We want the subsequent presentations to be able to address whatever challenges that we've had in the performance. So we would call Dr. Joshua. He is a public health specialist with the Disease Surveillance Department and currently the National Public Health Emergency Operations Center manager, to give us the presentation on performance of the AFP surveillance system in Ghana. So over, Dr. Atta.
Thank you very much, Dr. Tawab, and thank you to Dr. Lai for the introduction and setting the stage for us. I believe my screen is seen by all. As mentioned, we want to look at the performance of the AFP surveillance system in Ghana, and we would quickly look at a brief background of polio, wild polio virus, global polio situation, and we'll talk about how the surveillance system for acute flaccid paralysis operates in Ghana, and then we would zoom into some of the performance indicators, and we are looking at those indicators that we as individual practitioners have a role to help the country improve, appreciating that there are other system issues that may not really be something we want to focus on for now. So polio is an infectious disease, and there are 3 distinct serotypes of the wild polio virus, named type 1, 2, and 3. And polio affects mainly young children, even though people of all ages can actually have infection of polio. It is transmitted person to person through the fecal-oral route. So polio really operates similar in terms of transmission to what we know with cholera and other diseases like that. And once polio gets into the system, the virus multiplies in the intestines and then invade the nervous system from there, where we see the effects that we'll talk about a bit later. And for that same transmission route, the infected persons are then able to shed the virus through their feces for several weeks. So in areas where you've got poor water and sanitation, environmental health challenges, then the likelihood of infected water, infected food containing human waste with the virus is increased. And that is really how a lot of our children are at risk for coming into contact with the polio virus. Now, what happens when the virus enters the body? In truth, over 70% of infections are asymptomatic. A lot of these would even need an external trigger, sometimes trauma, to even make the whole infection symptomatic. And this is important when we think of differential diagnosis, and why even when it is clear that, okay, person fell from a tree, child fell from a tree or whatever, we still say, let's go through the AFP cascade and rule out that this child has not previously been exposed to the virus, and this trauma is what is triggering that. So it's important to note that over 70% of infections will be asymptomatic and in the absence of no external trigger may not even proceed to clinical infection. Now, out of this, you have, aside this, you have another 25% that may just have a fever and sore throat, constitutional symptoms. Nobody would really be thinking of such infection. And then you've got another 5% that may have headache, neck stiffness, myalgia, and typically recover in about 14 days. You would have a very small proportion, about 0.5% of cases, where you actually have muscle weakness that comes with paralysis or paralysis. And typically this involves the legs, but then it is not uncommon to have patients present with weakness that affects the head, the neck, and even the diaphragm. When you take out those that would experience muscle weakness, you'd see that adults are likely to have a bad outcome, with about 15 to 30% of adults maybe proceeding to death, especially when the diaphragm and the neck muscles are severely affected. There is also post-polio syndrome that may occur years later after the infection. And so you see a similar muscle weakness, just as we have described before, but this is really from infection years ago, and now it's manifesting. So it's important to think of all this spectrum of a presentation. Again, it is instructive for our detection so that we have that broad sense when we are thinking of AFP surveillance. And I think the subsequent presentations will get much into this. As described by the transmission, being in an area that has had a recent polio outbreak, being close to someone with active polio, being in the lab, handling specimen of the virus, and extreme stress or any external trauma that itself assaults the immune system can easily move someone from asymptomatic infection to active infection. Polio was quite rampant in the earlier years. However, the introduction of vaccines helped to really reduce the disease burden. And then again, also in 1988, the World Health Assembly resolved that by the year 2000, as much as possible, there should be a worldwide eradication of polio. And this led to the Global Polio Eradication Initiative to actually help in the implementation of this resolution. So the current activities we carry out in Ghana are attendant of this resolution. A bit about the current situation for polio. And we have come from a period where there were about 350,000 cases across 125 endemic countries from the 1988 to a few cases in 2021, got just about 6 or even less. And now for the whole world, there are only 2 countries, Afghanistan and Pakistan, that are still considered endemic for wild polio virus. For the wild polio virus, you've got 2 strains are considered eradicated. Type 2 and type 3 are considered eradicated. So Ghana, going along the JPEI strategy, adopts 4 main strategies for polio eradication. And that is routine immunization, supplementary immunization activities, the acute flaccid paralysis, that also includes environmental surveillance, where we are actually picking wastewater and testing in the lab to find out if these viruses exist in them. Because once they exist in the wastewater in the environment, it poses a risk to unvaccinated populations who could come into contact and actually experience the disease. And the 4th one being mop-up campaigns where there are areas of suboptimal coverage, vaccination coverage, to boost the population or herd immunity. And so a bit of focus on the AFP surveillance component of this four-pronged strategy. And we are looking at a system that looks for and investigates all cases. And maybe I should enlarge and bolden the all. The idea is that all cases of acute flaccid paralysis in children aged less than 15 years. For other age groups, we are interested in them when a clinician actively or directly suspects polio. And the aim is to determine whether any case of AFP is caused by wild poliovirus or any of the other variants of the virus. Now, the performance of the surveillance system is what actually holds a candle to the quality of the polio eradication efforts in any given country. And the surveillance system is what helps us to measure how much progress we have made towards the global polio eradication initiative. So this is to actually situate the reason for the surveillance system and to help us all understand why it is important to really be looking out for all AFP cases in children aged less than 50. So as I mentioned, the rationale is to detect circulation of wild polioviruses through detecting all AFPs. Now, our ability to detect all AFPs who may not have wild poliovirus helps us to also objectively demonstrate that, yes, we have AFPs in our country, but these are not being caused by wild poliovirus. So it's important that we are able to catch all AFPs, test them, and then be clear that these are not being caused by wild poliovirus. And of course, the surveillance system also helps to guide immunization activities. This diagram is just taking what I mentioned in general. So the appreciation is that there are a whole lot of AFP cases in our communities, presenting in our clinics and hospitals. And we want the AFP surveillance system, that net, to be able to catch all of them, for which we will do a case-by-case investigation and lab analysis. And we're able to catch which AFPs are due to wild poliovirus and which AFPs are not due to wild poliovirus, termed the non-polio AFP. So that is really the idea. Remember that AFP is something that would occur in our communities, present to our hospitals. So typically, when you talk to clinicians, they are like, but this is not polio. And you say, no, we are not saying it should be polio, but once it is a case of acute flaccid paralysis in a child under 15 years, it should be subjected to the AFP surveillance system. And that helps us achieve the objectives that we have mentioned previously. So how do we go about AFP surveillance? It's typically through reporting from the reporting sites, and these are public and private healthcare facilities. So all healthcare facilities, irrespective of ownership and level, are part of the reporting network. We're also looking at active surveillance visits to what we call priority reporting sites. And priority in the sense that you are considering the context and asking yourself, are these places most likely to treat acute flaccid paralysis patients? This may be major hospitals, large pediatric clinics, physiotherapy centers, traditional healers, bone setters, wherever, depending on the type of community you are dealing with. So you really just want to think of, if I consider my setting, where are AFP patients likely to go to? And for these areas or locations, we target them as priority reporting sites. And even in limited resource settings, you want to have or institute regular active surveillance visits to these places. And then, of course, the role played by our community-based surveillance volunteers, informants, community leaders, and other people who can actually bring information to us. So we really want to make sure that all these avenues for reporting are active where we operate so that they can help set up a very robust reporting system for AFP surveillance. How do we decide or agree that this is a case that should be part of our AFP surveillance? And so we use a case definition. And the case definition here is any child less than 15 years of age presenting with recent or sudden onset of floppy paralysis or muscle weakness due to any cause, or any person of any age with paralytic illness if poliomyelitis is suspected by a clinician. So please let's take note of the two parts of the case definition. For a child under 15 years, we are looking at any cause of the floppy paralysis or muscle weakness. And for any age, once we are making a very direct suspicion of poliomyelitis, then that also has to be subjected to the AFP surveillance system. So we look at the three components. We are talking about acute paralysis that's of sudden onset, and we'll talk about the issue of non-AFP cases. There are some cases that actually you go to look at and say that, oh, the child has not been working for since birth. Clearly, that is not an acute onset paralysis. Flaccid, so we are looking at paralysis that is floppy and not rigid or stiff. We are looking at paralysis, so we want to talk about loss of muscle strength. There should be demonstrated weakness, limiting movement, and all that. So for a case to be defined as a true AFP, then all three conditions must be met. And that is what we want to really communicate. I think this is the same information being put in terms of questions. So is the case less than 15-year-old? If it's an older case, is this a case that a clinician is suspecting polio? Is there paralysis or weakness of a limb? Is the weakness or paralysis sudden, appear within the last week? And is it also floppy? We need to have yes to all three, and then that case should be investigated as part of AFP surveillance. Please note that this investigation should be within 48 hours of notification. And of course, case investigation proceeds with laboratory analysis. And so for AFP surveillance system, we're collecting 2 stool specimens, adequate stool specimens, and we are collecting these ideally 24 hours apart and within 14 days of the paralysis. It emphasizes that timeliness. So somebody has come in and says, typically with our context, maybe they went 1 or 2 places already. Is day 8, is day 10? If it's business as usual, then it's likely that by the time you are getting around to collecting 2 specimens, you have already crossed the 14-day. And we'll show why it is important to look at the sample collection within 14 days. In Ghana, our samples are tested at the Noguchi Memorial Institute for Medical Research. And for each case, we do what's called case investigation. So complete demographic and clinical information is collected and input on a case investigation form. And now we are using an electronic platform called SORMAS, where you can record all the details, including GPS location, all that for the case in the community. And this is transmitted in real time to all the levels that need to work on that information. And you want to record neurological examination findings. So clearly, this can be done without the involvement of our clinicians. You want to pick vaccination history. You want to look at medical history and risk factor information. And if there has been history of travel, you want to record all this as part of the case-based investigation report that should be put together. Then there is an aspect of the surveillance system called the 60-day follow-up. So we are looking at follow-up on the 60th day after the onset of symptoms. So not when the person came to the hospital, but you are looking at the date of onset of symptoms when calculating 60 days for a follow-up. Follow-up consists also of a neurological examination and assessment for residual paralysis, especially if a case that was earlier, the case earlier reported, the lab came back and said, well, the stools were inadequate. And we will look at what constitutes inadequacy of stools. Once you have this situation, it's just mandatory that we have to check in 60 days whether there is residual paralysis or the case has fully recovered. And then this 60-day follow-up should also include a final clinical diagnosis. And I'm sure when Prof shares some of the challenges, you see that we're having a lot of cases come up. And like, what is the diagnosis? What is the clinician even thinking? Is he saying it's Guillain-Barré? Is he saying it is transverse myelitis? All that is not there. And that really impedes the quality of the surveillance system. We mentioned about picking the stool sample within 14 days of symptom onset. And this diagram here that shows the variable fecal excretion rate of the viruses in stool gives the reason why. You see that beyond 14 days, the level of excretion drops off significantly. And so you may be testing and saying negative, but it's just because of the quality of the stool. The other aspect is why we want to collect 2 stool samples at least 24 hours apart. You see the diurnal variation of the excretion rate, so that there are, within 24 hours, there's like a high point, a low point. So taking the 2 samples 24 hours apart increases the likelihood that you might be picking your sample at one of the high points, which increases the likelihood that you might find this with a laboratory analysis. So this is not just a prescription to just make the lives of staff difficult, but it's actually based on science. And if we are looking at the quality of the system, then we want this to guide us. A lot of times in practice, this is not easy, but with a bit of collaboration between clinicians, public health officers, and caregivers, it's something that can be done. And so we want to encourage that sort of collaboration that makes this possible. We mentioned adequate stools, and we're going to explain this, what it actually means, and then link it to what we said about the follow-up. So we talk about at least 4 different criteria. The timeliness, how timely has the stool been collected? Is it within the 14 days? We saw the chart and why that is good. Is it after 14 days? If it's after 14 days, then it's inadequate. How many have you been able to collect? Have you been able to collect 2 specimens at least 24 hours apart? Or you only collected 1 specimen or even none? If it is 1 or 0, then again, we say the stool is inadequate. The quantity, the amount to ensure that you actually can have a good yield of the virus if it is present. More than 8 grams, we say thumb size. If you have that, these 2 specimens being about thumb size, then that is adequate. If it is less, then it's also deemed inadequate. Now, after all this, how does the stool arrive in the lab? So at the lab, they would also look at that. And good news is that because of so much, they are able to put that information there. And they should be able to tell you that, okay, it is not desiccated, the stool is in good condition. Or they tell you that, oh, it came dried. Is the virus even alive? It came, it's leakage, it's not properly packaged. Or the cold chain was broken by the time it got here. Is the virus even still viable? So if you've got any of these, then you actually have inadequate stool. And if you have inadequate stool, then you remember that your 60-day follow-up is mandatory. It has to be done at all costs. Otherwise, it really makes it difficult to say that the case was or may not. Remember that majority may not be polio virus, but once this is not satisfied and the follow-up 60 days is not done, then we have to sort of err on the side of caution and say it is likely that this case was caused by polio, something like that. So it's important to really think of this. And at our facilities, at the district level, the regional level, we want to see how we put in mechanisms to ensure that we are able to really push for this. This is a bit about the classification. So you have an AFP case, you do the tests, adequate specimen, and you find no residual virus. You discard. It's an AFP, but it's not due to polio. AFP, you may have inadequate specimen, but you are able to do your 60-day follow-up properly, and you find no residual weakness, it will be discarded. If there is inadequate specimen, there's residual weakness, or you say, oh, case has died, or we couldn't follow up. When it is reviewed by the expert committee, they may, based on how much information you have provided, decide to discard because the information is helpful, or say that it's compatible with polio. And if the testing is directly finding polio, then of course we can say that we have a confirmed polio virus. So especially when we look at the second line, we have a lot of role to play in helping the committee to actually come to a good decision whether to discard a case. And we hope that this series help us all to do that. This is a bit about the indicators, and I will not really bore us with it, but it's just to emphasize that these things are part of measuring the performance of the system. And we are saying that for every 100,000 children or under 15 years of age, we should be able to achieve about 3 non-polio AFPs in a year. And then when we talk about adequacy of stools, we want to be sure that 80% of our stools are adequate. They meet the conditions that we have just discussed. So at this point, I just want us to quickly look at some of the things that the surveillance system has achieved. We'll run through briefly, and then maybe when it comes to the question time, we can have some more details. So prior to the 90s and 2000s, we used to record some wild poliovirus cases. But for Ghana as a country, our last case of wild poliovirus was recorded in 2008. Since then, we've had some cases from circulating vaccine-derived poliovirus too. And we've also seen an increase in the reporting of cases. And that some of it is due to some of these sensitizations that we are carrying out now. Our environmental surveillance has also identified the circulating vaccine-derived poliovirus in wastewater from different locations in Ghana. We've got this environmental surveillance spread across the regions, and weekly we are picking samples from them to test at the lab to see whether they have these viruses. So we can see that overall, reporting has sort of been quite high, going up in 90, 100 ranges. And then we are also not reporting any of the wild polio viruses. 2019, 2020, 2022, and this year that we have also had a CV-DPV2 reported through our environmental surveillance system. When you look at the cases by region, these are the regions that have reported some cases over the period. For 2023, for 2024 so far, we've actually not have a human case. So when I say CV-DPV2 cases, I'm talking about human cases. And when I say event, then I'm talking about finding the virus in the environmental surveillance system. And we've not had any of these cases in the past 2 years. And as I mentioned, reporting has generally gone up with some of these sensitizations, but we still note that in a lot of places, clinicians keep on saying they are not aware that AFP surveillance is ongoing and what role they can play. And some public health officers will still have challenges in actually doing meeting all the requirements of the system. Our non-polio AFP rate as a country has consistently stayed in the good zone, if I can put it that way. But if you look at the end, you can see that good zone, the line looks like it's dipping. So how do we maintain, how do we sustain the line looking up and not beginning to tip down like we are seeing in the chart there? Similarly, our stool adequacy rate at the national level, still in the good zone, still also you can see that the line is dropping down into the not so good yellow zone. And this is the national picture. When you start looking at it, the regional and even district level, then you find a lot of us in the yellows and even a few in the reds. So clearly there is some work to be done to keep these performance indicators in the good zone that they should belong to. As I mentioned, this year in 2024, September, we've identified CVDPV2 in the environmental surveillance, wastewater collection. And we've had about 806 AFP cases recorded, but out of these, 25 are not even AFP. It's not like they are non-polio AFP. They are not even AFP. When you look at the information and all that, they shouldn't even have been reported as AFP. And that is an indicator that we don't want to be doing so well in terms of numbers. So it is one of the reasons why we want to be familiar with the case definition so that we are actually picking AFP and not anything that we may be under pressure to just submit. We've got 16 districts from across 7 regions that, to use the surveillance term, are silent. They have not reported any AFP cases at all for the whole year and some even for 2023. AFP cases always present because like we'll see with Dr. Hamon's presentation, they are in the community. We need to be upping our ability to detect and report on all of these things. When we look at the performance that we saw for the country for non-polio AFP rate stool adequacy, we see that we have 11 regions that have been able to achieve this. We still have about 5 regions that are not doing so good with that. And when we look at our annualized non-polio AFP rate, then we are doing quite well, except Greater Accra that's having some challenge doing that. And that is a feature of some of the urban areas. So we also need to start discussing how we work in the urban areas, clinicians, public health officers together to really drive up this performance. And then, of course, we have about 5 regions that are also having some challenges with stool adequacy. And it's notable to have Greater Accra close to the center. And again, some of it is attendant to the urban dynamics. So we need to have some strategies around this. So to sum up some of the challenges, there's still a number of late reports, and these increase the chances of compatible cases. You see that the clinical information for most of the reported cases are inadequate. Diagnosis not there, follow-up, no clinical assessments. And as I mentioned, there are also silent districts that are not reporting any AFP cases, some for about 2 years now. When you look at the case reports, as I mentioned, once you have inadequate clinical and diagnostic information, it makes the classification a challenge. And the committee may end up having to say it's a polio compatible case. Again, if we are also not adhering to the case definitions, then our not AFP cases goes up, and that is not a good reflection of the surveillance system. So we are looking at how we improve clinician involvement, we improve reporting and documentation so that we can demonstrate better performance for the surveillance system. So to sum up, It's clear that we've had some progress when it comes to the global efforts to eradicate polio. There are a few challenges, especially inadequate clinical assessment, poor documentation, challenges with stool adequacy, and the like. And then, of course, the silent reporting or the silent districts. And we know that the key to detection also lies with our clinicians. And so we have to ask ourselves, what can we all do to step up this performance? And then when you have limited diagnosis and information on the AFP cases, you actually have a challenge with classification. So on that note, thank you very much for your attention, and we'll be looking out for any questions that we can address. Thank you.
Thank you very much, Dr. Ta, for the presentation. I'm sure during the presentation, majority of the clinicians on the call will be like, but in my consulting room, I've seen cases that meet this case definition. I was once like that. So maybe as a brief summary, I will just try and highlight the key areas, especially the case definition, because that's the critical part. So the case definition, any child less than 15 years of age presenting with recent or sudden onset of floppy paralysis or muscle weakness due to any cause, or a person of any age with paralytic illness if poliomyelitis is suspected by the clinicians. And also the AFP surveillance is just part of global efforts to be able to eradicate polio globally as part of the WHO resolutions. And some of the challenges that we have seen that has meditated this webinar is the low clinician involvement, especially in the assessment of cases. We are also seeing a lot of compactable cases due to late reporting and detection. And I mean, when the clinicians are strongly involved, they are the first point of call. So they are those who see the cases first. So if the awareness level in the clinicians is high, we'll be able to pick up our cases very early and respond to them, thereby reducing the number of compactable cases that we are having. By way of information, the registration link has been shared in the chat. Let's kindly complete it. And then the professional code for the allied health professionals, kindly take note of the code for your profession and make sure that we have the right code in it. Now that we've seen had an overview of AFP, what it is, we've seen some of the challenges and the performance indicators, it would be best to have a presentation on the role of clinicians in AFP surveillance and how clinicians would help us improve this performance. And this presentation is going to be taken by Professor Emmanuel Adoyobo. He is the chairman of the National Polio Experts Committee. So we are privileged to have Prof here take this presentation. So Prof, over to you. Thank you.
Hello, do you hear me, please?
Yes, Prof, please, we can
Hello?
hear. If you can put your presentation in slideshow.
Yes, I'm sharing. Okay, you've seen it, isn't it?
Yes, please, we can see the presentation.
Okay, right. Good afternoon, everyone. And I hope people are awake at this time of the day on a Sunday. But I think Dr. Laye and Joshua have presented the key concerns about all this hula baloo, if one may describe it, on the polio eradication and acute flaccid surveillance. Dr. Arthur mentioned some key issues, and I'm going to reiterate some of them as I focus on the clinician's role. A little apology. I have serious fluctuation of current. So I'm working with 3 computers at the same time, 2 and a tablet. But I'm using the best now. As soon as I go off, I'll switch on to the other. So bear with me if anything like that comes on. Right. So do you hear me so far? Can you confirm, please?
Yes, Prof, you can be
Hello.
heard.
Good. Right. Okay. So I'll continue. So I'll say a bit about the rationale and strategy for eradication. And then I would do a brief overview about the clinical requirements. This is where the clinician comes in. Then I'll talk about where the National Polio Eradication Committee, the NPEC, comes in and the challenges it has, because the conclusions from NPEC go onto the international dashboard. So all other countries are seeing how well or how badly Ghana is doing regarding data collection. And beyond that, or even before that, what we are doing towards polio eradication. Then I'll show some examples of the challenges we have with the focus on issues regarding the lack or absence of a clinician's involvement. Then I'll sum up the clinician's role and make some suggestions on a way forward. So somebody may ask, and I'm talking about this because if you know why you are doing what, you tend to do it with a bit more spirit. Somebody may ask, why polio eradication? And we know that man is the only host. Dr. Arthur said a bit of it. There are no permanent carriers. The virus does not survive long outside the human host. And there are effective vaccines. And it therefore means that if you kill the last man, there is no polio virus. And if we can kill the last polio virus, then there's no polio in man. And this is what is driving the eradication. When it started in the late 80s, it was meant to have been over by the year 2000. We are 24 years ahead, and we are still grappling with it, which tells us that we need to kind of improve on our game. And the strategies, as Dr. Arthur mentioned, are 3 main ones: a high immunization coverage, a good AFP or polio surveillance, and then environmental sanitation. Just to go a bit over, if everybody is immunized, then there is no way the virus can be spread from person to person. And if you are doing a good surveillance, as soon as it shows up, being the original organism or any mutant or other, then we'll be able to deal with it because there is a good vaccine for it. And even while we are not looking at the environment, because remember, a small proportion of infected persons who will go ahead and become paralyzed. Unfortunately, we are looking at those paralyzed, but there could be a number of them with polio who are not paralyzed, and we are likely to pick those signals from the environment. We also collect stool samples from the environment to see whether we can get traces. I mean, you can imagine that if all these 3 measures are well in place, we will catch the virus wherever it presents, and we have the machinery to deal with it, so we shall be able to deal with it and eradicate it. The other important thing is Ghana is not alone. We have neighbors. So even after or while we are doing our best, there are people who come in from other countries into our country who may bring the virus. And if you have virus in our country, people from our country may take it to other countries. So it's an ongoing game until the whole world or the whole of the sub-region is covered. And that is why we need to, as it will be said, shine our eyes in looking at whether there is polio or not, because we have the machinery to do with it. I'll go over briefly, just for, as a point of emphasis on the definition. And it's acute. Acute does not mean severity. It means a short time, duration, usually less than 3 days. And it's flaccid, as it was said, as opposed to spastic. And it's what? Paralysis. Sometimes people think of paralysis as what? Total loss of function or not being able to walk. But the definition of paralysis we are looking here, if you'd even dare to check in dictionaries, it's a failure to do what you were able to do previously with your limbs, a loss of function. It does not have to be a total loss of function. So weakness and, of course, inability to use the limb is what you are looking at. So it must have been sudden in onset, usually within 72 hours or 3 days. It must be floppy, and there must be limitation of movement, and these three conditions need to be met, sometimes with a fever, usually. He mentioned that we are focusing on children under 15 years, but if the person is older than 15 years, then there must be a suspicion of polio. And that suspicion certainly cannot be done by anybody else except a qualified clinician. I mean, a parent may come saying that I think my child has polio. That is good, but the documentation of it should be confirmed by somebody who knows how to distinguish between polio and other forms of paralysis, and more importantly, acute flaccid paralysis. So when we come to the surveillance activities, again, it's been mentioned, but I'm focusing on the part that is relevant to the clinician. So the first is identification of a case of paralysis. And we said it must be flaccid, it must be acute and flaccid in nature rather than spastic. And of course, there must be the weakness. Now, when you see this, or if this is seen and reported, there must be a system which starts from an individual who will fill a clinical form, and I'll go through the aspects of the clinical form that are relevant for the clinician, and then collect 2 samples 24 hours apart within 48 hours. Now, this is where sometimes the issues begin. If the stools are collected very far apart, then it breaches the criteria, more than 48 hours. The size, if it is too small, then the sample may be not enough to go through the lab processes for isolation and detection of the virus. So if it is too small, there may be the virus, but the machinery may not be able to detect it. Now, when the sample is collected, it's stored in a freezer, cold storage. We call it a reverse cold chain, because if you leave the sample on the desk outside the human body, you dry it up, it dies, and it becomes unviable for propagation, for growth. And this is a basic principle we know for bacteria, living organisms, right? So the essence is that the essence of storage is that the organism should not die before reaching the reference lab, which also means that in the process of transportation, if there is a chance of drying or warming, then it's likely that when it gets to the lab, the sample will not be viable. So we classify all cases of failure to meet the size, the storage temperature, and any chance of contamination. That will describe all that as the stool being, quote unquote, inadequate. So inadequate in quantity, inadequate in storage, and inadequate in timeliness. These are the 3 things we'll go by. Now, after the stool collection, we need to plan a 60-day follow-up. And the idea is that if it is indeed polio, which affects the anterior horn cells, it will lead to, a wasting of the affected limb. And usually this wasting will be obvious within 16 days. You might not see it in the first week or 2 weeks or whatever, but by 60 days, should there be any wasting, you would see it. And you see it from an inequality in the size and sometimes function of the limb that is affected. Then clinically, we will do things like look for muscle power that suggests weakness. We look for wasting. We do tendon reflexes, and then we test for sensation. Now, briefly, you would know that if the reflexes are exaggerated, then that is unlike polio, because in polio, the reflexes are down. But it means that somebody must be able to, elicit reflexes and elicit it well. And this is where, again, the clinician comes in. Is the person able to perform a good assessment of tendon reflexes? And therefore, whoever we send to do that kind of job, we must ensure has the competency. Now, when all this information has been collected, the data is brought to the National Polio Experts Committee. And there we have to go through to ensure that all the standards we've been talking about have been met. So we look at the appropriateness of the surveillance measures in each case. We look at the eligibility. Is the person within the age? Or if it is outside the age, has a clinician confirmed that in a way that polio is suspected? Then there's stool collection, the timeliness of it, with 2 stools within 48 hours. And then the storage, it is well stored. There's no chance of contamination, and there is no evidence of warming of the stool. And then, of course, the 60-day follow-up. It might interest you to know that when you fill the case investigation form, some of the basic clinical parameters should be demonstrable in the 60-day follow-up. So if it happens, for instance, that the paralysis is in the left leg, then after 60 days, the weakness is in the right leg, then there's something wrong. I mean, that is quite obvious. Then we also look at the labs. So when the appropriate criteria have been met concerning the labs in terms of adequacy of stool, quantity, timing, storage, and whatnot, and the lab comes and it says it's negative, hooray, that is our standard. But if the lab says, if it comes and it is positive, then we know we've got a case. If it is negative, we know it is not a case. But if it is negative and there are issues with the standards for lab collection, then it is likely to be a false negative. And this is where other issues come in. Now, based on that, we classify the cases based on the virologic characteristics. So basically, primarily on the lab. And when we are unable to do it from the lab, then we look at other clinical parameters to decide whether it is a possible case or not. And if it's a possible case, we describe it as compatible. And whenever you have compatible, it suggests there is a failure in the surveillance system. Then after that, because we have a wide net of all cases with acute flaccid paralysis, some can be Guillain-Barré, some can be trauma or whatever. In the absence of positive lab results, we look for a laboratory diagnosis for what will then be non-polio AFPs. They are AFPs, all right, but they are not polio. So the question is, what are they? And the idea behind is that you should be able to, once you've sorted out those that are polio, you should be able to classify as much as possible those that are not polio, because there are a number of differentials that will mimic polio in terms of acute flaccid paralysis. Now, based on that, we pick up a number of gaps. And as you heard from Dr. Atta's presentation, the country as a whole and some regions not meeting the surveillance requirements. All that means is that there are gaps. So we are not looking hard enough. And what that tells the international world is that should there be a chance of polio slipping in, we might not see it. And therefore, it will start spreading in country. It just means that our surveillance system is not good enough. Right. So now let's go to the details of the documentation as far as the clinician's role is concerned. And that is history taking and examination. All clinicians are supposed to be, to have some reasonable expertise in history taking and examination. And the demands are not great at all. So on the first day of case identification, the questions are, is there paralysis or weakness? And you can assess that using the usual clinical skills, or sometimes asking the person to walk. If he has a limp or an unsteady gait, it gives you a clue. Now, in this event, was there fever at onset? You get this only by asking. So if you don't ask, you won't get it. And then acute onset. Is the onset more or less than 3 days? Again, if you don't ask, you wouldn't know. So if you see that section on the form being blank, it means the person did not ask or he was incapable of asking. And I don't know what other reasons can be attributed to that, except for the fact that the person asking is not a clinician. And then, is the weakness flaccid, floppy, or is it spastic or rigid? That can also be easily determined by somebody who has clinical skills. And then the progression. Did it progress in less than 3 days or in more than 3 days? There are other conditions where the progression goes on for more than 3 days. For instance, Guillain-Barré. But in polio, it's usually less than 3 days. And then symmetry. On the form, you see the word asymmetry. What it means is, if I should go, excuse me if it's below the belt for people, but if it's a left leg and a right leg, then it's symmetrical. If it's only a left leg or a right leg, then it is asymmetrical. And that also applies to whether it is left-sided, left upper limb and lower limb, or right upper limb or lower limb. So we have hemiplegia or paraplegia or monoplegia, depending on what it is. And of course, you have to document the site of the paralysis for consistency. So as I've put down here, all these things are essentially activities that acquire some clinical skills. Now, on the 60-day follow-up, remember we said that if it is polio, we expect that by 60 days, there will be significant wasting that will be detectable by the clinician. So first of all, is there still weakness in the affected limb? If you ask the person to walk, you would know. If he cannot walk, you compare one leg to the other in terms of power, you would know. The site of paralysis, is it the same? Has it changed? The good thing is that a different person may do the assessment on the first day, and a different person will do the 60-day follow-up. So we look for consistency. When it is the left leg one time, and then it becomes right hand the other time, then there is really something wrong. Then is there floppiness, the site, the muscle tone. So here the symptoms may be over, but the clinical findings will be there. So muscle tone, deep tendon reflexes, muscle volume, sensory loss, and when these have been answered, then a provisional diagnosis. So remember that when we say acute flaccid paralysis, it's an epidemiological diagnosis. It's a descriptive diagnosis. It's not a fixed clinical diagnosis, because under that we have a number of diagnoses. So the clinician should be able to say, yes, this is acute flaccid paralysis, but in my opinion, this is the most likely reason. And of course, anybody who's gone through some clinical training will be able to make some informed guesses. And of course, the comments are very important because they help us put meaning onto the differential diagnosis and the symptoms or clinical signs that were detected. So if you have any comments, please jot them down. That additional information may not necessarily be classified on the form, but like I said, it gives us insight as to what to happen, because our job is to declare whether it is truly acute flaccid paralysis, what does the lab see, what are the possible diagnoses, and we should be able to do this regularly to show that, yes, the watchman is keeping watch all the time, not that sometimes he's sleepy and he doesn't see what goes on. So this is an example of what you may see on a 60-day follow-up. For those of you who may not be appreciating it, you may perceive that this limb, I hope my cursor is showing, this limb, the right limb, is smaller than the left limb. Now, if you look at the posture, the way it is resting, this is the normal resting place, position of a limb. But you see that this one is turned inwards. And you can probably, with an eye of faith, realize that it looks like these tools are more energetic than these ones. These ones are critical. Of course, the difference in size you can tell, the calf muscles especially. And of course, this limb looks weaker than the other one. But of course, if you ask the person to walk, you will see certainly that this person has a gait. Now, when we come to the case investigation form, let's focus on the part that is relevant to the clinician. When I say clinician, I mean somebody who sits in the consulting room to see patients and evaluate patients and give recommendations thereof. So we have notified by, the person's name will be there, date of notification, date of investigation. So it may be notified on one day, but the investigation will start on a different day. Is the person hospitalized or not? Date of admission will be there, hospital record, name of hospital. So that should there be any need to look back, we can go back and trace. And there's basic information. Is there fever at onset? If it is yes, it's a 1. Is paralysis progressive, less than 3 days? It's yes. But if it's a no, then it means that question was not asked. This is basic clerking, isn't it? And if it is, if it's no, then it's negative. It's more than 3 days. But if it is unknown, then the question was not asked. Then the date of onset of paralysis, because sometimes historically, the person is seen at a later date than the date of onset of the paralysis. So that gives credence to the information. And then is the paralysis flaccid and acute? If it is yes, yes, 1. If it is not flaccid nor acute, it's no. So you put a 2 there. Sometimes people you could tell that it's probably a mistake between the yeses and the nos. But please pay attention to what you put in, because you are looking for a logical flow of the information. Now, asymmetry. So if it is both lower limbs, then it is symmetric. If it is symmetric, it means asymmetry would be no. If it is one limb, then it is asymmetrical, which means asymmetry would be yes. And people, I urge you all to pay attention to the narration or what you put into this box. Now, this box is a proof of what has been said. So whether it's symmetric or asymmetric, you come and tick here, whether it is left arm, right arm, left leg, or right leg. So once somebody says it is symmetrical or asymmetry is 2, then it's probably some 2 ticks here or up there. So anything else brings conflict between the 2 pieces of information. Then there are other things. Is the paralyzed limb sensitive to pain? So this must be done by somebody who knows how to test for pain reasonably, as clinical methods should say. And then, was there any injection? Because as you may have heard it from Dr. Arthur's presentation, that sometimes trauma and injection can trigger the paralysis. So we also need to know. And if so, the site of injection. So you realize that this side is purely a clinician's activity. Then when you come down, so after all that, after investigation, was this a true AFP at the bottom? It is quite impossible to go through all that and have issues with this bit unless the person filling it is not a clinician. So if it's a true AFP, there should be paralysis, it should be progressing within 3 days, and it should be acute. That makes it a true AFP. So if it is, then it is yes. And if not, then it is no. And then you are supposed to provide a provisional diagnosis. So this activity is quite clinical. And should we let people who are not clinical do it, there must be supervision from a clinician. Otherwise, it's degrees of confusion, and it reflects the clinical skills of the district or region where it's coming from. Now, on the 60-day follow-up, as I said, we do similar things, but a little differently. So on the 60-day examination, is the weakness still present? It may be not, it may be there, yes or no. And where is it? Left arm, right leg, right leg. And ideally, when you look back on the case investigation form, it should be consistent. Otherwise, there's something wrong. Yes, sometimes it may not be consistent because you are talking about a different diagnosis altogether. So the investigator should just document what he or she has seen, provided he or she has the requisite clinical skills to make the correct conclusions. Right. Then when you come down, muscle tone. So the person performing it must be capable of assessing muscle tone to see whether it is increased, decreased, or normal. Tendon reflexes, whether they are normal, exaggerated, or diminished. Muscle volume, whether it is normal or wasted, because here they cannot be don't know. If you don't know, then the person hasn't got the skill. And then sensory loss in paralyzed body parts. Is there any other place where there is sensory loss? It's a yes or no. And then a provisional diagnosis. So it may be that the diagnosis on the early form is different from this, depending on what is actually the case and what is the clinical competence of the one doing. And of course, comments are always welcome. As I said, it gives insight as to what should be the real diagnosis. So now we move on to the classification, and this must be done within 90 days. And I've put that in yellow because anything that we cannot conclude on within 90 days of reporting is considered a failure of the surveillance, because you don't want to come back and say, oh, 2 years ago, we found somebody with paralysis. I mean, the opportunities for rectification and actions are gone. And as I was saying, we will confirm if it's a true AFP or not. Then if the stools are adequate and the transportation and the storage and everything is adequate, then we confirm the case as either being a case of polio or otherwise. If it is otherwise, we discard the stool. I mean, in which case the stool is adequate, the lab results are negative, and there's no residual paralysis at 60 days, especially if the stool is inadequate. So you would realize that anytime the stools become inadequate, be it in terms of quantity collected or the storage or the process of sending it to the lab, then it is mandatory to do a 60-day follow-up. Otherwise, the case will be classified as compatible, and that means that it's a surveillance failure on the part of the district or the team. Then we review the diagnosis and we assign diagnosis for the non-polio AFP. If it's non-polio, what is it? Is it Guillain-Barré? Is it traumatic neuritis? Is it transverse myelitis? Whatever. We put it there. And then we go ahead to look at the AFP surveillance performance indicators, which Dr. Atta was talking about. And then we advise the Secretariat on further actions. So for instance, the districts that are silent, all it means is that they are not looking. And if they are not looking, then indeed there could be cases of polio there which they are missing. And recently, it was more of an issue of the vaccine-derived poliovirus 2 that was associated with paralysis. That also needs to be done when looking at adverse events following immunization. So this is essentially what we do, and this is what we go through. I won't go through all the details, but first of all, we want to capture whether it's AFP. And if the lab is fine, we pick a wild polio. Yes, we confirm. We pray that we don't do that, but we don't miss the opportunity. And if there is no virus, but the stool is inadequate, then we look at the 60-day follow-up to conclude on all these things, whether there's residual paralysis or not. And if there's no paralysis, we discard. If there is paralysis, becomes compatible. And of course, if 2 specimens have been taken and everything is fine, we discard. So this is essentially the business of the expert committee, and this is where actions will take place for the classification. Now, if the stool is adequate and we don't find any wild polio virus on examination, then it's not a case of poliomyelitis because the lab is negative. Now, then we start to consider what are the possible diagnoses. Dr. Hammond will go more in detail about this, so I'll probably maybe mention a few things. If there is paraplegia, it could be myelitis. If there's hemiplegia, it could be encephalitis, there and on. So we go through that. That is more of the work of the experts committee. But of course, the clinicians can give us a heads up on that based on what they think. If it's a true AFP and the stool is inadequate, so there are chances of false negatives, isn't it? So the first is that we've possibly missed a wild poliovirus detection due to the inadequacy of the stool, and the MPEC will classify it as compatible. Also, if the child dies before the 60-day follow-up, it's a loss to follow-up, isn't it? So that also becomes compatible. And if the presentation strongly is suggestive of poliomyelitis, then we take the necessary action as to be taken on the surveillance part. So if it is not a case compatible with polio, then we must also provide a diagnosis according to the findings on the 60-day follow-up. Right. I've mentioned this, so I would probably, probably it's good to still mention it because the issues we have stem from these ones. The first question is it a true AFP? So if the clinical assessment is poor or the documentation is poor, we cannot take that decision as to whether it's a true AFP or not. And then if the lab fails to detect polio, then you have to look at, is the stool inadequate? Is it small? Was the cold chain broken? Is the stool samples collected more than 2 weeks apart? And then, more than 2 weeks after the onset? And then, is it possibly contaminated? Where the stool collection bottle is not tightly covered, sometimes there's spillage, and there's contamination. But this is just to emphasize the 60-day follow-up is crucial. It helps us iron the dots and cross the T's. So our issues have been, as was said, but I'll go through a few examples. Conflicting clinical findings or reports, clinical competence challenges in case recognition and urological examination. And then we are seeing a lot of inclusions of non-AFP cases. Somebody with cerebral palsy is entered as AFP. Somebody with severe malaria, and for that reason, the person is unconscious. It is reported as AFP. I would dare make a joke about this, that if somebody is knocked by a car and is unable to walk, will you include that as AFP? But these are some of the arguments that come up. And then sometimes we see spurious or unconventional diagnoses and terminologies, and we wonder whether it is clinicians who are making the diagnosis or not, and whether there is any supervision. Because if these go to the international level, sometimes we expose ourselves to professional ridicule, right? There's two collection challenges: specimen size, timing, interim storage, and transport mechanisms. And of course, I just mentioned supervision. And we expect that the surveillance standards would be stable and improve. But sometimes the indicators are up, sometimes they are down, and it gives the impression that the players are probably being changed, or probably there is no, should I call it, in-service training to re-emphasize the expectations and the skills. And then sometimes the forms are inadequately or incompletely filled. Sometimes you could see there's a clear confusion. The one filling the form is not sure of what spasticity or flaccidity means, especially on the 60-day follow-up. And as I was emphasizing, AFP is not a clinical diagnosis. It's a surveillance diagnosis. So it is good to, it's a working diagnosis. It's good to put the real suspected diagnosis as part of it. So I'll go through some of the examples on the forms just for us to see. So if you can see this one well, those are tagged red. The record is that this is asymmetric. And asymmetric means it's one limb, isn't it? But here it's been ticked that it is both left and right, which means it is symmetrical. So, and then the diagnosis written is acute flaccid paralysis. It should not be. The diagnosis should be something else that the clinician thinks. The case is an acute flaccid paralysis, all right, but the diagnosis is something further than acute flaccid paralysis. And then the one who does the 60-day follow-up also says suspected poliomyelitis. Maybe that is fine, but we should see clinical information that fits it. Poliomyelitis is usually not symmetrical. And then it is floppy. So this one should have been a yes. And then the muscle tone should be decreased, tendon reflexes decreased, muscle volume should be wasted. So the clinical information at 60 days is not consistent with the diagnosis. So our dilemma is, what is it? And if the comment is the child is suffering from neurological syndrome, it only suggests that the one reporting probably needs some clinical assistance. This is a bit too, I don't know the word to use, but a non-clinician could be saying this. So we need more information than this one, right? If you look at this one to a similar thing, so here symmetry is not ticked, but 2 ticks have been given here for the left and the right limb, which means the person filling the form does not understand this asymmetric bit. And then paralyzed limb sensitive to pain is not ticked, which means this person is not probably capable of doing that assessment. And then the diagnosis is general weakness in both limbs. I mean, excuse the comment, but any health worker, from a statistician to an orderly to a consultant, could make this. So this is not specific enough. Not surprisingly, the one who filled the form cannot tell or did not fill this form as to whether it's a true AFP or not. The conclusion, even before I get to the conclusion, is that clinicians must be involved in this. Now, the 60-day follow-up give a diagnosis of cerebral palsy, yes, which is clinical, affection of upper and lower limbs, but this side was not filled. And it says, child has apparently been reviewed by a pediatrician and there is a high suspicion of cerebral palsy. So really, if it was the same time, the pediatrician should have helped fill the clinical assessment part, and that makes life easy for the committee to classify cases. Then sometimes there are detailed examination notes that follow. And if there is a system for supervision, we should be paying attention to that. It says the child has not gained neck control even at 1 year. He was picked out from the village during outreach, which means that this is not an acute condition. It happened a long time ago. He has a convergence squint, muscle is slightly increased, ankle reflexes brisk. So cerebral palsy, yes, that's the diagnosis, and that is not acute flaccid paralysis. This should not have been included. And should I mention it here that in your indicators, you are supposed also to calculate the non-polio AFP rate. The idea is that it gives the impression that even though you are not getting, polio cases, you are looking. So if your non-polio AFP rates are 0, then it just means that you are not looking. Now let's go on. If you look at this one, a similar thing has happened with the symmetry and asymmetry. There is no diagnosis. When it comes to the 60-day follow-up, they computerized it, isn't it? So it's a yes and a yes, so it's still left leg and right leg. And that is a bit not consistent with what we are looking for. And the tone is decreased. He says the provisional diagnosis is query AFP, very severe debilitating condition. This one just suggests that a clinician was not involved. He has no reflexes on the lower limbs. There is loose body parts, loss of muscle tone, blah, blah. This is a 14-year-old. And they did well to take this picture to help. So if you can take pictures and attach the documentation. Sometimes it helps. But if you have a condition where you have wasting and you are losing body parts, it means that there is loss of sensation. And this one has been going on for a long time. So this is not an AFP, something else. A similar one in this, I think the problems are just about the same. So for the sake of time, I will skip it. Now, if you look at this diagnosis, it says the provisional diagnosis is uncomplicated malaria. But really, will uncomplicated malaria, my question is, how is it linked to acute flaccid paralysis? Because you have a diagnosis, all right. And on the 60-day follow-up, it says muscle stiffness of unknown cause for surgical review. So certainly, I think a doctor's input was missed here. This also will go as possibly a non-AFP. It is not an AFP. So it reduces the denominator based on which we calculate your non-AFP rate. And on and on and on. So here, fever at onset, there's no response. Progressive within 3 days, no response. This just means that a history was not taken. And asymmetry not filled, but he has 2 ticks here. So this is hemiplegia. It gives the impression that the one who filled is not somebody in the clinic who sits and sees patients. But don't forget that we see who filled it here. So there is a way of looking at whether it's a cursory activity or it's a serious activity. And the diagnosis is query AFP. So the person who filled himself or herself is not sure whether it's AFP, but the same information is provided here, and he says it's yes. But this yes is erroneous because the basic fundamentals of talking about AFP are also not captured. And if you see a comment like the child looks sick, the mother can say that, a nurse can say that. I mean, you don't need to be a health professional to make this judgment. So we need more than that. And on and on and on, several of those examples, cerebral palsies, somebody with delayed milestones. And you realize that when a medical officer comes in, sometimes we get more information that helps us to conclude. So rounding it all up, the challenges are with the neurological assessment and clinical skills of those involved in AFP surveillance. And the impression is that the clinicians are not involved. And if they are involved, probably they didn't pay attention to the demands of the form. It also tells us that those involved, the team, the AFP surveillance team, and certainly it must be a team. The supervision is probably poor, and we need to pay a little more attention to the documentation and to avoid delays in classification. So I was asking questions. Are there teams? And a year ago, thereabout, in some of their workshops, we emphasized that there should be teams. If there are teams with assigned roles, you do this, you do that. If there's a need for training, you know what to train people on. If somebody in the team leaves, you know how to replace somebody and what that person's role should be. And it calls for succession planning as well. So without all those things, it becomes difficult. So summarizing on the clinician's role, they must be involved in case identification as per the case definition, because remember that if you are older than 15, there must be a clinical suspicion of polio, and that must be documented. And it involves taking history, neurological assessment, that is also clinical, assigning a provisional diagnosis is clinical, filling the form, it must be guided by a clinician, ensuring stool collection and storage, usually the nurses or the lab persons will do that. So you are beginning to see the importance of teamwork in this. And then scheduling a 60-day follow-up. I must say that you may pick someone and teach the person how to elicit the clinical signs properly, and you can dispatch that person to go and do a 60-day follow-up with the clinical skills you've provided, but it is unfair and unright to just send anybody at all, especially one who has not have a clinical background, to go and do a 60-day follow-up. And of course, we ensure that there is correct documentation. The forms must be reviewed before they are forwarded to DSD or National to make sure that unnecessary gaps are not left. And I mentioned delegation here. If you can't do it, please delegate. Dr. Atta has mentioned the surveillance indicators, so I'll skip that. And on the concluding messages, we need to be sure and consistent with the appropriateness of the enrollment and clinical reporting, stool collections, the follow-up, and documentation. I'm emphasizing teamwork, teamwork, teamwork. We need to build competencies, either engage people who are competent or train people just on the demands of AFP surveillance. In our in-service training, we need to think of capacity building. We need to look at our lab for storage of specimens. And periodically, we need to have meetings to bring out local challenges, which we will fix as time goes on. So basically, that is it. With these, I think it's obvious that AFP surveillance must improve. It's needless to say that poor performance is just a reflection of our competencies, gaps in our competencies, and we should be living above that. The clinician's role is vital, and once again, teams should be established. Thank you very much, and later on, we will listen to and try to answer any questions that may come thereafter. Thank you.
Thank you very much, Prof, for the presentation. And from Prof's presentation, it is clear that for us to be able to improve our AFP surveillance system, the role of the clinician is very critical. Even from the first day that the case is picked, the clinical history needs to be accurate. The 60-day follow-up where the neurological examination is done, the clinician's role is very important. And I'm sure the provisional diagnosis, when Prof shared some of the samples, you could see acute flaccid paralysis, but Prof says we shouldn't put that. So in place of acute flaccid paralysis, as Dr. Atta presented earlier, they are made up of several disease conditions. There are several things that go into the AFP package because we want to make it large so we can be able to pick it up. So to be able to take us through that presentation will be Dr. Charles Hammond, consultant pediatric neurologist at Konfanochi Teaching Hospital. He'll be taking us through the differential diagnosis and clinical examination for acute flaccid paralysis cases. So Dr. Hammond, over to you.
Okay, thank you very much. Please, can you confirm that you can see my screen and then can also hear my voice?
Yes, please. We can see your screen and can hear you loud and clear.
Okay, thank you. So, good afternoon, good evening to all of us. We'll be looking at differential diagnosis of acute flaccid paralysis and some very simple ways of doing the clinical examination. Yeah, and before then, we'll look at a few definitions. I think they've been mentioned already, so that makes it easy. And then we'll try to look at the differences between flaccid and spastic paralysis. And then we'll list a few differential diagnoses and then go on to the neurological examination at the 60-day follow-up. So we'll start with the definitions. When we talk of tone, we are talking of the resistance to passive movement at the joint. So when I hold your limb and I try to move it at the knee, there is some resistance, and that is what we call the tone. So when there is increased resistance, then the tone is increased. And when there is decreased resistance, the tone is decreased. So increased tone can be referred to as spastic or rigid. I think for the purpose of this discussion, we'll be using spastic more. I don't want us to go into the details of what is rigid. But when it is increased, for the purpose of this discussion, let's call it spastic. And when it is decreased, it is called flaccid. Some books will say floppy, but we are using the term flaccid. Then another term that needs definition is paralysis. I think Prof. Adiobo did a very good job when he said it means weakness. It doesn't mean a total loss of power is paralysis, but sometimes there is a mild loss of power. It is still paralysis. So when there is a degree of weakness, that is also paralysis. So I want us to go back to tone again. And we said that when there is increased tone, we are saying there is increased resistance at the joint when it is moved. And these are often caused by lesions in the brain or the spine, what we call upper motor neuron lesions. And these will include things like stroke in children, cerebral palsy, hydrocephalus, spinal compression. So things that affect the brain and the spine, or what we call upper motor neuron lesions, will often give us increased tone or spastic paralysis. Then things that give us decreased tone are the ones that affect the lower motor neuron lesions. And the lower motor neuron starts from the anterior horn cell. That is the junction between the spine and then the peripheral nerve. And that is where polio affects the nervous system. So the anterior horn cell, lesions in anterior horn cell will give you flaccid weakness or flaccid paralysis. Lesions in the peripheral nerve, lesions in the neuromuscular junction, and then lesions in the muscle will all give you flaccid weakness or flaccid paralysis. Examples of conditions that will, and then let me also add that the initial stages of upper motor neuron disease can also give you flaccid weakness. So the things that I mentioned, the stroke, cerebral palsy, and spinal compression, and all others, which are upper motor neuron disease, usually in their initial stages, you may have a flaccid weakness. So if somebody presents with a stroke, he had a stroke yesterday and came to your clinic today, the person will not have spasticity. The person will have flaccid weakness. It will take some time, maybe a couple of weeks, before the tone gets increased, before spasticity sets in. So example of an anterior horn cell disease, I mean, as we've been talking about all this time, is poliomyelitis. An example of peripheral nerve disease, which is also a very good differential of acute flaccid paralysis, is Guillain-Barré syndrome. And then when you go to the neuromuscular junction, myasthenia gravis is a common example of a neuromuscular junction disease. And then when it comes to the muscle itself, there are so many conditions that can affect the muscle to give you flaccid weakness. Some of them are inflammatory conditions like myositis. Then you may have some genetic disorders like congenital myopathies and Guillain-Barré's, Duchenne muscular dystrophies and many other genetic conditions. But myositis is common and it can be caused by viruses. So here I have tried to present a table that will look at the differences between flaccid paralysis and spastic paralysis. So first is a site of lesion, and I've already explained that for flaccid paralysis, the lesion is in the lower motor neuron, which is either the anterior horn cell, the peripheral nerve, the neuromuscular junction, or the muscle. Whilst for spastic paralysis, the lesion is in the upper motor neuron, which is either the brain or the spinal cord. When it comes to the appearance, the flaccid weakness often presents with wasting or atrophy. And we saw from the pictures Prof. Adiobu presented to us where you have asymmetric wasting. So with appearance for flaccid paralysis, with time, wasting sets in. With spastic paralysis, they don't often have wasting. Most of the time, it is normal. A few may have wasting, but most of the time, it is normal. Then when you look at the state of the muscle, they are limp or floppy in flaccid paralysis, whilst they are stiff in the spastic paralysis. The muscle tone, we have talked about that before, it is decreased in the flaccid paralysis, whilst increased in the spastic paralysis. The muscle power, of course, is decreased for both of them, but it is markedly decreased in flaccid paralysis compared to spastic paralysis. Then tendon reflexes are absent in flaccid paralysis, or they are very low in flaccid paralysis, whilst in the spastic paralysis, they are brisk or exaggerated. Sensation is usually intact in flaccid paralysis, but in spastic paralysis, they may be intact or they may be lost. So most often when you have loss of sensation, it is not flaccid paralysis, because in flaccid paralysis, mostly sensations are intact or they are present. But I must say that some peripheral nerve disease may present with different sensations. So sensation is not completely lost, but there may be hyperesthesia or some other form of sensations, numbness or something, when peripheral nerves have been touched. Muscle power is decreased in both of them. I think this is a repetition of bullet number 5. I'm sorry about that. The nerve control of the muscle is lost. So there's loss of voluntary control in the flaccid paralysis. Whilst in the spastic paralysis, there is hyperexcitability leading to the uncoordinated movement. Or sometimes we see things like clonus. These are because of hyperexcitability of the nerves. I don't want to dwell so much on that. On this slide, I would want to go to bullet number 11, which says the purpose of our webinar today. So for the differential diagnosis, there are a whole lot of them. And it will be good it is good to have a good clinical examination, history and examination, to get closer to one of these differential diagnoses. We heard Prof. Adiobu rightly say that you cannot say your differential diagnosis is acute flaccid paralysis. That is a surveillance diagnosis. But once you get that, what is causing the acute flaccid paralysis is important. And you must do a good clinical evaluation, that is history and physicals, to be able to get to the right diagnosis. So obviously for flaccid paralysis, the first we want to talk about is paralytic poliomyelitis. But then we also have conditions like Guillain-Barré syndrome, transverse myelitis in the initial stages, even though transverse myelitis affects the spine. So it is usually an upper motor neuron disease. But I said that in the initial stages, it will present as flaccid paralysis. So transverse myelitis is a very, very important differential diagnosis of acute flaccid paralysis. And then traumatic neuritis. In this instance, there is always trauma, either from ingestion or from other forms of trauma. So traumatic neuritis is also a common cause, especially when children have had intramuscular injections. And then conditions like encephalitis, meningitis. Remember, I said that these are upper motor neuron lesions, but in their initial stages, they will present as flaccid weakness. And then some infections. So polio virus is an enterovirus, but it is so important that we separate that one. And then there are many other enteroviruses, and then we put all the others together as non-polio enteroviruses. So if you take enteroviruses, we classify them as poliovirus and non-polio enteroviruses. So it's like saying Ghana and then the rest of Africa. So you can have other non-polio enteroviruses causing flaccid paralysis. So that is important. And then you can have other viruses like echovirus, Coxsackie virus, all of them causing flaccid paralysis. When it comes to spastic paralysis, the differentials obviously will include things like cerebral palsy, strokes, paralysis from other causes, spinal cord injuries, compressing injuries, and then sometimes we have what we call congenital spastic paralysis. You may have tumors, you may have tumors of the brain, tumors of the spine, some infections like cerebral toxoplasmosis, TB of the spine, TB in the brain. These will all cause spastic weakness. But let's remember that in their initial stages, they will have flaccid, they will present as flaccid weakness. So again, this is a diagram I'm sure many of us have seen before. Very, very important, talking about the differential diagnosis of acute flaccid paralysis. And so you may have poliovirus, Guillain-Barré, Coxsackie virus, traumatic neuritis, transverse myelitis. Remember the other viruses, the non-polio enteroviruses, and then also echoviruses. This will all cause acute flaccid paralysis. So we've heard a lot about polio already. This is just one slide to summarize what poliomyelitis is. It is caused by the poliovirus, which is an enterovirus, and the transmission is fecal-oral. And initially, it presents as non-specific symptoms. So fever, fatigue, headache, vomiting, pain in the limbs. So anyone can say this is malaria, or this is gastroenteritis, or this is something else. So this is non-specific. Okay. And then we are saying that 1 in 200, I think Dr. Atta said that 0.5%, which is 1 in 200 of the people who have the infection will have irreversible paralysis. And that is what we call paralytic poliomyelitis. And this will lead to wasting or decreased muscle bulk, weakness or decreased muscle power, floppiness or flaccidity, and then there'll be decreased or absent deep tendon reflexes. It is usually unilateral, but it could be bilateral, but most of the time it is usually unilateral. And then sensation is intact. So if you have a patient with a sensory level, a patient who has lost sensation up to mid-thigh or up to the umbilicus, it is not likely to be polio because polio presents with intact sensation. Among those who are paralyzed, about 5 to 10% of them will die when their breathing muscles become involved. And this is what we call bulbar polio. So you can have a condition called bulbar poliomyelitis, where the poliovirus affects the brainstem, or what we call the bulb. So the anterior horn cells, some of them are also located in the brainstem. So if the virus travels up, and then affects the anterior horn cells in the brainstem, then the patient will present with difficulty in breathing. And if not properly supported, the patient will die from what we call bulbar poliomyelitis. The next slide, we want to talk about Guillain-Barré syndrome. This is a disease of the peripheral nerve, and it is an inflammatory condition which affects the myelin. The myelin is the covering of the nerve, the myelin of the peripheral nerve. So we say that it's a demyelinating disease, demyelinating because it affects the myelin and sort of removes the myelin from the peripheral nerve. And as I said, it is an immune response, and it often preceded by an antecedent viral infection. About half of the patients would have had some viral infection about a week or two before the onset of the weakness. And these viral infections could be respiratory tract infection or gastroenteritis, but respiratory tract infections are more common than gastroenteritis. It presents in 3 phases. There is a progressive phase. That is when the patient rapidly becomes flaccid. And then there is a plateau phase. The patient stays stable at that phase for a long time. And then there is a recovery phase. And then within that phase, there is regain of function in a reverse order to the progressive phase. So patients with Guillain-Barré can have full recovery if given the proper support. The clinical features are progressive motor weakness with areflexia. I've highlighted the areflexia or absence of reflexes because these are very, very important. And then the weakness is progressive. It may be ascending or descending. Most of the time, it is ascending. So it starts from lower and then comes up. So, I mean, no patient will come to you and say that I have weakness, which is starting from lower and coming up. It depends on how you put your questions. So, for example, a 3-year-old or a 4-year-old, initially they will complain of muscle cramp in the lower limbs, and then they will then lose the ability to walk. So they are not able to walk, which means their lower limbs have been affected. When it gets to the trunk, then they even lose the ability to sit up. So they will tell you that first he said he was walking with a limp. Let's say he was walking first with a limp. Then later on, he couldn't walk completely. Then now he can't even sit. And that gives you an idea that it is progressing and it is ascending in nature. And when it comes to Guillain-Barré, most of the time it is symmetrical. So both lower limbs are affected. Both sides, left and right, are affected. So I'm sure we are putting in our minds, we are trying to tell the difference between poliomyelitis and then Guillain-Barré syndrome. Poliomyelitis will not be ascending. Guillain-Barré will be ascending. Poliomyelitis is unilateral most of the time. Guillain-Barré is bilateral most of the time. The weakness progresses rapidly in Guillain-Barré, reaching its maximum within 2 to 4 weeks. So remember, I talked about the progressive phase. So the progressive phase may take up to 2 to 4 weeks. And then you may stay in the plateau phase for a long time. That one is not very defined, but it can be for months before you recover. And the recovery phase is a mirror image of the progressive phase, but in reverse order. Guillain-Barré is also associated with autonomic dysfunction. So they may have BPs going up and down. They may have arrhythmias and other things. And then there is also, there may be facial involvement. So facial nerve can be involved, or some cranial nerves can be involved. And when that happens, we call that the Miller-Fisher syndrome. Again, Guillain-Barré, just like polio, Guillain-Barré can also have a respiratory involvement when the bulbar nerves are affected or bulbar dysfunction can set in. When bulbar dysfunction is setting in, so there are some pointers to tell you that you are going to have bulbar dysfunction. So a patient may have difficulty swallowing, patient may have a weak voice, a weak cough. These may all set in before a total respiratory failure sets in. And then I said that in the recovery phase, it's a mirror image of the progressive phase. So there could be a recovery of function within 2 to 4 weeks. Another very important differential diagnosis of acute flaccid paralysis is transverse myelitis. This is an inflammation of the spinal cord. And so ideally, or in its right place, it is an upper motor neuron disease, but it presents with spasticity later on. So the initial phase, it will present as floppiness, and so it becomes a differential diagnosis of acute flaccid paralysis. And it is due to an immune-mediated mechanism. And again, some viruses and bacteria have been implicated, but the symptoms are symmetric weakness in the lower limbs. So again, you have another condition presenting with weakness in the lower limbs, and it depends on the level of the spine which has been affected, okay? And then there is also a deficit in sensation. So this is the one that will present with a sensory level, depend on the area of the spine which has been affected. And one key thing about transverse myelitis is that there is loss of sphincter control. So there could be loss of bladder control, there could be loss of anal sphincter control. And loss of bladder control will present with incontinence, or sometimes not necessarily incontinence, but you have inability to void. So they will have urinary retention because the sphincters are not loosening up for urine to pass out. And then they may also have constipation because of the anal sphincter not loosening out for feces to pass. And then this, when prolonged, then leads to leakage of feces, or what we call fecal incontinence. Again, it's associated with autonomic dysfunction. So you may have high or low BPs, etc., etc. So let's get into the habit of checking blood pressures for some of these patients. I know we don't often want to check blood pressures for children because we say there are no appropriate size cuffs. But the same people who buy the adult size cuffs should be told that some of our patients are children, and so they should also buy the smaller cuffs that we can use for our children. Again, this is a very important table which highlights the 4 main differential diagnoses of acute flaccid paralysis, and it talks about certain key features. So the 4 main differential diagnoses are poliomyelitis, Guillain-Barré syndrome, transverse myelitis, and then acute traumatic neuritis. So when it comes to the progression, poliovirus progresses very fast, usually within 24 to 48 hours. Guillain-Barré is quite varied. It can go from hours up to about 4 weeks. Transverse myelitis is within days, hours up to days. And then traumatic neuritis is also within days. And it will usually affect only one limb, whilst polio also affects one limb. It is asymmetrical. Guillain-Barré will usually affect both limbs, and it is mostly ascending, and then it is symmetrical. Sorry. And then transverse myelitis also affects both limbs, and it is symmetrical. The deep tendon reflexes are absent or decreased in all of them in the initial phase because they will present as flaccid paralysis. But for acute transverse myelitis, it becomes breaks in its later phase. Fever is common in poliomyelitis, but not common in Guillain-Barré syndrome. For transverse myelitis, it may or may not be there. And then for traumatic neuritis, it depends on what the underlying condition is. Of course, if the child had malaria and then someone gave an artesunate injection into the bottles, then the fever is due to the malaria and not necessarily due to the traumatic neuritis. And when it comes to sensory symptoms, polio usually does not have sensory changes. Guillain-Barré may have some tingling sensations, or as I said, there may be cramps in the lower limbs before the weakness sets in. Transverse myelitis usually has sensory symptoms and will have a sensory level. When it comes to traumatic neuritis, there will be pain in the gluteal region, and then later on, there could be sensory manifestations in the affected limbs. Cranial nerve involvement is important for bulbar polio, and then also for Guillain-Barré when there is bulbar involvement, but it is absent in transverse myelitis and traumatic neuritis. Respiratory insufficiency, when there is bulbar involvement in polio, you have respiratory insufficiency. In Guillain-Barré, again, when there is bulbar involvement, there will be respiratory insufficiency. Transverse myelitis usually will not have, and then in traumatic neuritis, it is completely absent. Autonomic symptoms will be present in Guillain-Barré, and transverse myelitis. Bladder dysfunction, as I said, they are present in transverse myelitis. You hardly see that in poliomyelitis. Occasionally in Guillain-Barré, some of them may present with bladder disturbances. When you do cerebrospinal fluid, which is a very important investigation to do in the hospital, for Guillain-Barré, you see abnormal CSF counts. The reason is that there will be increased protein, but no cells. That is very, very important in Guillain-Barré syndrome. They tend to have increased protein, but no cells. In poliomyelitis, it depends on when the CSF is done. It may be abnormal. They may be due to cell counts, but mostly it is the CSF is very, very important in Guillain-Barré, where you have increased protein and no cells. And for transverse myelitis and traumatic neuritis, CSF is usually normal. Sometimes in ADAPT centers, they do what we call nerve conduction studies. I'll skip that because we don't do a lot of nerve conduction studies in Ghana, but it is basically looking at the speed at which the nerves are conducting the electricity along the nerves. And it will be affected in poliomyelitis and Guillain-Barré syndrome, and also in traumatic neuritis. The diagnostic test is very, very important. We need stool samples, the correctly collected stool samples. I think Prof. Adiobo and Dr. Atta both took us through the proper stool samples. We need that for poliomyelitis. For Guillain-Barré, nerve conduction studies are done, and for transverse myelitis, you may have to send to a tertiary center for MRI. And for traumatic neuritis, nerve conduction studies are done. But because they all present as acute flaccid paralysis, and polio is so important, we need to report to the public health authorities or the disease control officers in our facilities to get stool samples taken for all of these conditions. Prof. Adiobo talked extensively about the 60-day follow-up, so I will just summarize it in this slide, and I think we'll be heading to the end. So approximately 60 days after the onset of the paralysis, all surviving patients must be examined again for residual paralysis. Residual paralysis simply means, is the paralysis still there? So the 60-day follow-up exam should be done by a well-trained officer. So usually we have people who are not clinicians who go to the field to pick up the cases, and they fill the case identification form. But when it comes to the 60-day follow-up, we expect a well-trained officer to do that portion for us. So we need a well-trained officer who has a good knowledge on how to do the neurological examination. And this report is very important for the classification by the NPEG. And in some cases, you will have to refer the patient to get a senior person, because we all have different levels of expertise. You may have to refer to get a senior person to conclude on your findings. So a further evaluation may be required by a senior person. Sometimes when you are not very skilled and you put down the findings, it becomes very difficult. And then we keep sending them back for you to send to a senior person for confirmation. So finally, I'll conclude with a tidbit about doing the neurological examination. I'm sure we all do it, but we've probably not been very consistent. So it is good to refresh our memories on how to do the neurological examination. There are general aspects, and then you'd want to do cranial nerves, a brief examination of the cranial nerves, because of the likelihood of bulbar weakness that we discussed for polio and for Guillain-Barré. And then more importantly, you want to do a motor and a sensory examination. I think that is what the form really requires of us, motor and sensory examination. So the general aspect, you want to look at the patient's appearance, wasting, whether the patient is using attachments like wheelchair, crutches, and these are all very important. Level of consciousness, mental state, dysmorphic features are very important. Sometimes you have a patient with some weakness, but the patient already has a dysmorphic feature. And if you try to tie it in, then it is not an acute condition. It's probably a chronic condition. For children, they are always growing. So their body sizes and shapes are changing. So we like to have measurement. So measurement of things like weight, height, head circumference, head shape are very important. If you are entertaining conditions like meningitis or encephalitis, then you have signs we call meningeal irritation. So you look for the signs of meningeal irritation. And a very common sign of meningeal irritation is neck stiffness. So that alone tells you that you are dealing with something like meningitis or encephalitis. And for those who may be aware of other signs like the Koenig sign or the Brzezinski sign, these are very important. And then you look on the skin for any lesions on the skin that may be pointers to neurological conditions that we call neurocutaneous manifestations. Again, if you see some of these things, then you tie it into the weakness, then you can say that it is a chronic condition, something that has been there for a long time and not necessarily an acute flaccid paralysis. Then the next thing you want to do is the cranial nerves. I want to skip a lot of them and then go straight to the common ones. So look for ocular motility, how the eyes are moving. Is there a squint, for example? Okay, so we saw one of the patients who had cerebral palsy, who had a squint. And then look for facial weakness. If a patient suffers a stroke and comes to deviated face, that is because the facial nerve has been touched. And then hearing and other things. But more importantly, for acute flaccid paralysis, look for bulbar function, look for swallowing, look for cough, gag reflex if you can do it. And it is not comfortable. So you only do it for the unconscious patient. Look for voice projection. If the patient is not able to project their voice, this possibly bulbar weakness is about setting in, and then tongue protrusion and all other things pertaining to the bulbar function. And now I want to come to the very important aspect of the examination, which is the motor examination. And it is important to look for the posture and the gait. The difference between the gait and the posture is they are all looking at how your limbs are in relation to your trunk or the rest of the body. But for posture, it looks at this relationship when you are lying down or you are sitting down. And for gait, it looks at this relationship when you are upright or you are in motion. So that is that. So if you can do both of them, that is fantastic. Or you can do one of them, depending on what the patient can do. If the patient cannot walk, then you can only do posture. Muscle bulk, we can't stop mentioning it. It is so important in the evaluation of the patient with acute flaccid paralysis. It can be wasted or normal. But in some conditions, in some genetic conditions, you can have hypertrophy. And that should tell you that you are not dealing with acute flaccid paralysis. But it is important to pick up the wasted or the atrophy limb. And then look for abnormal movements if they are present. Look for other deformities like contractures, club foot, spine deformities, and these may be pointers to a more chronic condition. Then, importantly, look for the tone. And we are saying that the tone will be either flaccid or spastic, or it may be normal. It's very important to be able to pick up the flaccid tone. And I'll show you some very simple ways of picking up the flaccid or the spastic tone. The muscle power or the muscle strength is also important. It may be normal or reduced. And reflexes is, again, a very important component of the exam in deciding whether this is an AFP or not. In most AFP, reflexes will be absent or decreased. If you have Brick's reflexes, then you are dealing with an upper motor neuron disease, a disease of the brain or the spine, not necessarily an acute flaccid paralysis. And for when there is no lesion, you have a normal reflexes. So this picture is just telling us about how to examine for tone. So for example, you move the arm using the elbow as your fulcrum or your pivot. So you move the arm at the elbow. and you look for the resistance in movement. If there is increased resistance, then the tone is increased or spastic. If there is decreased resistance, then it is flaccid or floppy. When you examine for power, in clinical terms, we grade power from 0 to 5. But to make it very simple, just ask the patient to walk. If the patient cannot walk, then there may be reduced power. But it's not always that there is reduced power because the patient cannot walk. Sometimes the patient may have pain or something. That's why they are not walking, not necessarily reduced power. But then if they have pain, you can ask them to lie down and then move the limbs from one side to the other, move it up against gravity. And if they are not able to do some of these things, and sometimes move it against resistance, if they are not able to do some of these things, then you have reduced power. And reflexes, you always need a reflex hammer to do. Some of the reflexes are quite difficult to determine, but the easiest one is the knee jerk. And we should all be able to do the knee jerk because that is very easy. When you do the knee jerk, in a normal patient, you have a very small jerk of the leg. But if it is an acute flaccid paralysis, most often you will not get any jerk. And then if it is an upper motor neuron lesion, you get a brisk jerking of the leg. You can also check the reflexes at the elbow, hitting on the biceps tendon or the supinator or the triceps. And these are all easy ways of checking for reflexes. Sensory level, again, we have learned that it is important because in some of the conditions like transverse myelitis, you may have sensory deficit. So look for light touch, look for deep touch. Some people call it pain, but we in pediatrics, we like to call it deep touch because pain is not pleasant. So look for deep touch, look for light touch. Some patients may have temperature losses and then loss of joint position sense. So this is my final slide, and it shows some very, very, very useful pictures. The first picture to the left, all these three patients have weakness in their lower limbs. But let's look at the differences very well. The first one to the left, the child has been lifted up, and you see that the limb is stiff because there is no bending at the knee. So the leg is lifted up together with the thigh. Whilst in the picture in the middle, the child's left thigh is being lifted up, and you can see the foot drop in the left foot, and that tells you that that is a flaccid weakness as compared to the first one on the left, which is a spastic weakness. Again, the one to the right, the third one, the child has been lifted up in a similar way to the first one. And you can see how the foot has dropped. The leg and the foot have dropped. So that tells you that that child has spastic weakness. So the two on the extreme, on the left and the right, are doing the same thing, but they have different outcomes. And just this simple maneuver, you can tell that one of them is a spastic weakness and one of them is a flaccid weakness. So this will bring me to the end of my presentation, and I'm sure we'll take more questions from now on. Thank you very much.
Thank you very much, Dr. Hammond, for the presentation. Maybe before you go, I've seen that the presenters have done so well by answering most of the questions that are in the Q&A. But there's one that, Dr. Hammond, I want you to take before you leave.
Yes.
So there's a question: what treatment is given whilst awaiting results from a suspected polio case? And two, how is a positive polio case managed?
Okay, so there is no specific drug for treating polio. Like many viruses, there is no specific drug for treating polio, but there are supportive measures, and these supportive measures are very, very important. So if you highly suspect polio whilst awaiting the results, one of the key things is bed rest. It is so important to ensure bed rest for the patient. And then you also have to give adequate pain relief, adequate analgesia, because it can be very, very painful. So you give adequate analgesia, especially in the acute phase. So bed rest, analgesia are very, very important in the acute phase. And then the patient needs muscle relaxation. And then you should watch out for respiratory compromise. So once you suspect polio, it is important that you refer to a center that can provide respiratory support. You don't have to do vigorous physiotherapy in the acute phase. Remember, I'm talking about bed rest, and then because it can be so painful, you give pain relief. No vigorous physiotherapy, and then you provide respiratory support. But once it enters the recovery phase, you have to do intensive physiotherapy, and this will help to minimize, to regain muscle strength and function, and then not to have a total loss of muscle strength. So you do vigorous physical therapy only in the recovery phase. And then you may need things like speech therapy to assess bulbar function and then to help with swallowing. And then you may also need occupational therapy. And then post-polio, because if the patient doesn't succumb to the disease, the patient will survive, even though the patient may have a weakness. Post-polio, you may have to do assistive devices and orthotics to help with mobility. Some patients, because of prolonged immobility, may develop contractures, and you may have to do surgical interventions to relieve contractures. And then psychosocial support is always very, very important. So these are the supportive measures for managing a case of polio whilst awaiting the results, or even if it is confirmed. And I hope this answers the question. I think there was a second part of the question, Doc, if you can remind me.
No, I think your answer
has taken care of that.
Summed up. Yes, you've taken care of
Thank you.
the answers. So I don't see any more questions. So maybe we'll give just a minute. If there are questions, colleagues should kindly post. If not, we would prepare to take the closing remark from Dr. Lai, and we would end the session. Yes, Dr. Atta.
Yes, I wanted to make a clarification. I think a link was put up for registration. I think many that came later got confused about the purpose. Please, I think most people on here, and even those who have been redirected to YouTube, did register for a Zoom link where we were asked to put our details, professional PIN, and all those things. If you have done that, that is all. We noted that for the allied health professionals, they needed to also include a code, and some indicated that they had registered without knowing that code. So that is why the second link was given. It is basically to get the allied health professionals to re-register, and it now indicates the code. So it's not a code for everyone to just go on. When we have a lot of duplicates, sorting it out will delay the whole process of accreditation. So I just want those who have joined to understand the value of that registration so that they don't feel that they have to just go on and do it plenty to assure accreditation. Thank you.
So, Dr. Atta, since you are still on the floor, please, what are the preventive measures in place? Maybe you will just take that, and then we'll go. If not, I can start, then you will finish up.
Okay, please continue.
So for the preventive measures, if you looked at the various risk factors that are there, they are mostly going to look at the sanitation issues. So issues, since it's orophycal, the sanitation practices, sanitary practices, hand hygiene, and all that would be part of the preventive measures. Then the vaccination that we do for children would be one of the preventive measures that are in place. Dr. Atta, I don't know if there's more to add, Prof, and the rest, if there's more to add, you can add. Then
Yes,
we'll take it from
I
there.
think the sanitary measures, and then of course vaccination. I think especially when we talk about circulating vaccine-derived poliovirus, a lot of us practitioners, clinicians get confused and say that they are getting it from the vaccine, so why are you giving more vaccine? But the idea is that the poor environmental sanitation, all those things actually mean that when children under 5 especially are not vaccinated, then the risk of having polio is higher. So really, good vaccination coverage is another important preventive measures, especially in light of the structural issues around poor sanitation, exposed drains, and all those things. So we want to really encourage that sort of health education and encouragement when it comes to taking our vaccines, whether it is the routine, whether it's any of the supplementary immunization activities, like recently they had the NOPV. Sadly, the teams will come back and tell you that, oh, the people giving them the most headache are health workers who are asking, oh, why do I have to take it again? Why do I have a whole lot of things? So we want to appreciate that, especially with our poor environmental sanitation, which sometimes goes beyond us as individuals. The vaccination is also an important preventive measure. Let's put all those together and let's see how we make it work. Thank you.
Yes, can I add something to
Yes,
emphasize?
Prof. Yes, Prof.
Yeah, a lot of us are very happy with sachet water. And there are some studies done by, one is Prof. Yawadu Sarkodie and co. that suggests that in certain parts of Kumasi, for instance, about 70% of the sachet water being sold is contaminated. Now, it could carry polioviruses or any other fecally transmitted organisms. The good thing with polio is that if a child receives the oral vaccine, it is shared through the feces. So if he defecates and contaminates the environment, then whoever is drinking the contaminated water theoretically is also being vaccinated. What I'm driving at is the key preventive measure seems to be vaccination, even though we emphasize sanitation and things like that. And I think that is very important to encourage the children to go for vaccination. It's usually their pool that we throw about. Adult pool tends to go into proper toilets and things like that. So if we encourage those eligible for vaccination to go for the vaccination, then we are all protected. Otherwise, we can all be at risk, and especially the adults, because they are not eligible for the EPI, polio vaccination. Thank you.
Thank you very much, Prof. and Dr. Atta. There's a question. My auntie had polio when she was young. Later, my father had hemiplegia after a fall. I want to know the case of my dad. Could it be polio? Dr. Amon?
Yes, I mean, I think the answer is in the question. The father had hemiplegia after a fall. Is that what you said?
Yes.
Yes, so it cannot be polio.
Okay.
So
Thank you very much.
The two events are very different.
Then there's a question. Please, for the allied health professionals, what role can we play? Dr. Atta?
I think Mr. Wavunyako is on hand to answer that question. He's been
Okay,
itching
Isaac
to
is on
answer.
hand to answer. Okay, so Isaac, over to you.
Okay, thank you, Dr. Atta. Thank you, Dr. Tawab and the other panelists. I think for the allied health professionals, we have a key role to play as far as AFP surveillance is concerned. Most of the time, we are responsible for supporting the investigation of the cases, supporting sample collection, supporting completion of the form, and even supporting the conduct of the CCD follow-up. So we have key roles to play as far as police surveillance is concerned in all its aspects, from case detection right through to the CCD follow-up and even case classification. Thank you.
Okay, thank you very much, Isaac. I think that was the last question. So, Dr. Lai, please, if you can give us the closing remarks so we can end today's session.
Dr. Tao, if I can I think I've seen a question. Sadly, I think it was put in the chat. They wanted Prof to clarify the symmetry thing before. I think it's something that confuses a lot of clinicians. So if we can make maybe a quick summary of it, and then maybe we'll close.
Okay, I think I missed that. So,
Right.
Prof.
Okay. So when you say symmetrical, literally it means the left side is mirroring the right. You get it? That is what it means. So if it's symmetrical paralysis, then what is on the left is the same as what is on the right, and vice versa, right? So I should not be using the word right because sometimes it's confusing. If they say symmetrical, then what is on the left is the same as what is on the right. If it is asymmetrical, then it's only on one side and not the other. I hope that clarifies it. So if we say somebody has symmetrical weakness, then it means it's both the left and the right sides. If it is asymmetrical, then it is either the left or the right, but not both. I hope that answers it. And remember, we can have upper limb and lower limb, upper limb or lower limb, or both upper limb and lower limbs. So if you have left upper and left lower, that is one-sided hemi paralysis. If you have all four limbs, then it's tetra, right? So hemi, tetra are all not asymmetrical. They are symmetrical. I hope that clarifies it.
Yes, Prof.
Right. Okay, thank you.
Thank you very much, Prof. So, Dr. Laye, over to you.
Thank you very much, Dr. Tawab. Prof. Adoyebo, you've reminded me of my days as a medical student and how much I didn't like neurology. I'm hoping that the explanation you've given to our participants on the call has been very well taken. I didn't like neurology. I think I can say that with confidence, especially now that I'm public health.
Don't say it loud. I think you like it better now, isn't it?
But thank you very much. I have to say thank you again, Professor Adoyebo, my lecturer, for the very insightful presentation. Dr. Hammond as well. I think that you simplify neurology, and it's very good to hear you talk on this call. And of course, to my colleague, Dr. Atta and Dr. Tab, for their roles, their respective roles. Dr. Arthur for giving us the public health flavor as far as AFP surveillance is concerned, and Dr. Tawa for moderating. I want to thank participants. I think it's been a very good meeting for us. The questions and the responses that we've been able to give on the call, I think this is probably better than when we are asking for questions on the floor. And so I think we will keep to this. I would encourage us to not just take this as getting CPD points. The question about the role of the allied health professional, I know Isaac mentioned all the spectrum of things that we could be involved in, but I think that, for example, if you're a health information officer on this call, think about where you could be identifying potential cases of AFP. Just collecting the routine OPD records should be able to help you, for example, pick a case that may have been missed based on the symptoms the patient presented. But that is also assuming or hoping that the case definitions have been made available to everybody to be able to prompt us to pick this. So across, for all of us, there are roles we can play, and I think that let's leave this meeting with that clarity that we have a specific role to play. From the clinician, both the doctors and the physician assistants, all of us, health promotion, health information, disease control, and all the others, we have a role to play. So thank you all very much. I think this will be our last CPD for the year. we're going to keep up with these online CPDs to continue to sensitize eyes, all to protect the health of our country, everybody living here, citizens and the likes. So thank you all very much once again, facilitators, and thank you, participants. I wish you a very good evening. Thank you, and over, Dr. Taab.
Thank you very much, Dr. Lai. Thank you to everyone for making this session a success. Thank you and see you another time. Bye-bye.
Thank you. Bye-bye.
Bye-bye.
Thank you, everyone. Please respond to the evaluation when you leave the Zoom. Bye.